So welcome to this session. It's on the structural determinants of HIV. My name is Professor Sheila Tlo, one of the founder members of SAH, and I'm with Professor Nkandulio. I'm sure you saw us at the opening. She is the founder member too of Society for AIDS in Africa, as well as Society for Women in AIDS in Africa. So I think she'll be happy to listen to some of these presentations if the presenters are here, because one of it is boosting PMTCT uptake, and then also looking at some discrimination and all that. So let me find out first. I'd like to get them to the stage. Husna, Baffa, please come onto the stage. I want the presenters all on the stage so that when we can start as soon as possible. And then my next is William Ansah. All right, Bill, right in there. And the last one is Dr. Airat Bakare. So there's no Bakare. Okay, that will enable us. So we have two presenters. That will enable us to have time for some discussion. So we're going to start without much ado. I simply want to let you know that the time is 15 minutes. After 10 minutes, I will remind you that you have 5 minutes. And when you see me stand up, just know that, you know what, it's time to wrap up. So if you are using slides, I'm hoping they are as succinct, as short as possible. So welcome. Let me start with the very first person who will be sharing her knowledge with us right now. It's Miss, is it Husna or Husna? Okay, it's Miss Husna Baffa, and she's a public health specialist, a nurse. I'm a nurse too. Welcome. The world is ours. And she's talking about reimagining health workforce strategies. And the question she's asking is, should we integrate traditional birth attendants, TBAs, to boost PMTCT uptake? And what are the lessons learned from Kano, Nigeria? She's an activist, as she's already stated. She's looking at humanitarian issues aligned with the African Union's agenda of 2063. She's a public health specialist who oversees the implementation of TB and HIV in Kano State, Nigeria. She provides technical expertise in healthcare to healthcare workers in the management of TB, HIV, and also in the strengthening of health systems in Kano, Nigeria. She is a member of the Young People Action Health Team, YPAT, for UNICEF Generation, and Generation Unlimited in Nigeria. And she provides solutions for young people through trainings, workshops, and conferences. Please welcome Husna.
Good afternoon, colleagues. Good afternoon, friends, and good afternoon, everyone in this hall. This afternoon, I'll be taking you through my presentation. By the way, my name is Husna Baffa. I work for Knowledge Network for Disease Control and Vigilance, known as KNCV, and I'll be taking you through the presentation titled Reimagining Health Workforce Strategies. Should we integrate traditional birth attendants to boost PMTCT uptake in Nigeria? What we learned in Kano State. I'm presenting this paper on behalf of my co-authors, who is here with me. Thank you. So my presentation is going to take this outline. And by way of background, in Nigeria, the prevention of mother-to-child transmission remains a public health priority, yet services uptake is limited, particularly in rural and underserved areas. It looks all gloomy and nice in cities and also metropolis. However, we still have some work to be done in rural and underserved areas. In the cities, we know that services are actually, basic services are accessible. But however, in underserved communities and also the rural areas, these services are not even accessible. And even if they were accessible, we need to do a lot of work to raise awareness among these people. Studies have shown that traditional birth attendants conduct over 25% of deliveries in some parts of the country, making them a vital community health volunteers. However, you could see how critical these community health volunteers are, because these traditional birth attendants are domiciled in these communities and they have gained trust in those communities, and there are a lot of people that patronize them because they believe in them. But however, their exclusion from the formal health system create a gap in reaching HIV positive pregnant women. Trust me, as an African, you know how our people patronize this traditional birth attendant. A woman might be pregnant and then in her next doorstep, she will just go to the traditional attendant telling her that she has this pain and all of this. So if we don't empower this traditional birth attendant to identify this danger sign and how to refer this positive pregnant woman or even screen them, then our PMTCT uptake will not be optimal. So, however, integrating the traditional birth attendant into the PMTCT strategies through training and, of course, linkage system has been shown to improve early HIV testing and also PMTCT uptake. So, particularly, this paper will be talking about how empowering these traditional birth attendants has changed narrative and also bridge equity gap. This intervention was started last year in August, from January. So, however, last year in August, we were able to map out this traditional birth attendant across all the local government areas, that districts in the state. This traditional birth attendant were identified. They were trained on how to screen test these pregnant women in the community as they come to their houses for HIV, of course, who of course are not attending antenatal. So each traditional birth attendants were mapped as spoke. We implemented a hub and spoke model where the traditional birth attendant home will serve as a spoke, then the ART comprehensive site was served as a hub, where whatsoever referral system the TBA refer this pregnant woman not attending antenatal to the hub site. We had also a very multi-pronged approach. We had community volunteers. These community volunteers were also trained to supervise this traditional birth attendant and also collect data from the TBO homes and upload it on the national data reporting systems. Additionally, we had also mentor mothers who are people living with HIV were also linked to these traditional birth attendant homes. In case when they have a positive pregnant woman, these mentor mothers will refer this pregnant woman to the ART site, where the mentor mother follow up this pregnant woman until 18 months postpartum. So we wanted to analyze the performance. Okay, when we didn't engage traditional birth attendant, and then after training them and engaging them, what happened? So, between April to September 2024, we had only 1,343 pregnant women. We were testing through house to house and also during outreaches, with 3 positives identified and referred for care. 981 were tested for syphilis, and we had 23 tested positive for syphilis, and were also referred for treatment. Following their training, we saw a significant increase between October to March. We did 6 months per year and then 6 months after, in number of pregnant women tested rising to over 56,000. Then also positive pregnant women also rose to 99, from 23 to 99. This was a simple bar chart that we did pre and post training of these traditional birth attendants, and you could see how the difference was it's clear and also obvious. So you could see if we didn't actually engage this traditional birth attendant, we would just be missing a high number of positive pregnant women in the communities, and of course our PMTCT uptake will still be suboptimal. So in conclusion, the results have shown that training and integrating traditional birth attendant into the PMTCT strategies not only boosted the uptake of service, but completely changed the landscape, providing better access and bridging the equity gap among these pregnant women. So we also recommended that further strengthening of the traditional birth attendant in terms of referral and linkage mechanism to ensure further reach at eliminating mother-to-child transmission of HIV. So these are some beautiful pictures during the supervision to the traditional birth attendant home, and this was some of the community health volunteers that were doing house-to-house visits. Lastly, I want to acknowledge my co-authors for their invaluable inputs, traditional birth attendants, my organization for their strong leadership and mentorship, Kano State Agency for Control of AIDS for their giving us a conducive environment, NEF1, Institute of Human Virology, Nigeria and Global Fund for giving us these funds to implement this intervention, and of course Icasa for giving us the platform to showcase this intervention. Thank you and over.
Yeah, and she kept to the time, actually saved quite a lot of time, so it gives us a little bit of time for important questions and discussions. And basically, she's talking about the Bamako Declaration, which was done a long time ago. We're hoping that by now, a lot of our countries are actually integrating that, the declaration to actually say we are going to have to augment our services by having traditional birth attendants. And as she said, there's a boost in terms of uptake and all that. So equity issues then become lessened. Okay, so our next person is presenter is William Ansah. He's from the Local Government Service of Ghana, and he's assessing the effect of conflict of HIV delivery, a case of Bawku Municipality, Ghana. So he's a highly motivated and result-driven Assistant General with a decade of experience in Ghana's local government service and specializing in administrative efficiency, staff welfare, performance management, and local government, operational, and as well as looking at focal persons, being a focal person for HIV and AIDS. He's currently serving at the Bawku Municipal Assembly and successfully streamlined administrative processes, enhanced staff development initiatives, and contributed to effective governance and policy implementation. And he's actually going to tell us how that is with a Master's of Public Administration from Samkyunkang University, South Korea. Annyeong Hashimnika. I'm with you. Yeah, thank you. Give me my hand.
Thank you so much. My name is William Ansah, and I work with Ghana's local government. This afternoon, I'll be presenting on assessing the effects of conflict on HIV service delivery, the case study of Bawku Municipal, Ghana. Okay, next slide. My presentation will touch on introduction, methodology, results, conclusion, and then recommendations. Next slide. Okay, so Bawku is found in the northern part of Ghana, specifically the northeastern part of Ghana. It shares border with two countries, Burkina Faso to the north and then Togo to the east. Bawku has been marked by a long-standing conflict, one which has been periodic. By periodic, I mean there are times the conflict flares up and there are times it gets so cool. But the conflict has been one of ethnic and is dispute over chieftaincy and land. Now, the conflict dates back to pre-colonial era and then goes into post-independence era in the 1950s. And then in the 1980s, it flared up again under President Rawlings. Then in early 2000s and then 2008, it once again flared up. And then more recently, in December 2021, the conflict flared up. With the conflict coming into Bawku, the main Bawku hospital has been affected. It's running below optimal level. Now, the Bawku hospital serves Bawku and neighboring districts. The neighboring districts include Pusiga, Binduri, Garu, and Timpani. These 5 districts do not have a district hospital. So the Bawku Hospital, which is built by the Presbyterian Church, serves these 5 districts together, working in hand together with other health centers. So on this study, we are going to look at the effects of conflict on HIV service delivery. Doing a literature review on the effects of conflict, we are well aware what conflict can do. Conflict leads to death and injuries. It also leads to spread of communicable diseases such as respiratory diseases. It causes anxiety and causes stress. And more importantly, conflict affects having access to health services. Okay, next slide, please. So the methodology used was one of a mixed method approach in which quantitative and qualitative methods were combined. Quantitative-wise, we looked at we did a comparative analysis of the ART attendance as well as HIV testing rates by comparing the pre-conflict years versus the post-conflict years. The conflict flared up in December 2021. Okay, previous slide, please. I'm not done yet. So quantitative-wise, we use data from the DIMS, that's the District Health Information Management System, where we got our rates, our attendance, and then qualitative-wise, we did interviews with key persons living with HIV as well as key health workers who work at the facilities and also the disease control officers who work at the municipal health directories as well. Next slide. So this gives us our quantitative results. The blue line represents the ART attendance, and then the red line represents the HIV testing. Looking at the blue line, that's ART attendance, we see that from 2020 to 2021, that's the pre-conflict years, it was rising. But then when the conflict set in 2021, it declined very sharply and then remained stable at that level. Likewise, the HIV testing also was on an increase till conflict setting, and then it declined and begins to fluctuate. Next slide. So the results reveal that there is a clear decline in HIV service uptake following the onset of the conflict. The ART attendance dropped by over 50% from its 2021 peak, while the testing rate also declined by 53%. All right, so we also conducted interviews with, as I said, key health workers and persons living with HIV. We did ask them about attendance, facility operations, how the ART attendance was, whether they were lost to follow-ups, whether they were default rates. We did ask health workers about staffing, their strength and the morale of staff. We did ask them about also communication, how they did communicate with clients whenever insecurity sets in. From the results from the interview pointed to service disruption, decline in ART attendance, staffing challenges as major perceived barriers. With regards to the disruption, we saw that the interviewees did indicate that there was widespread loss to follow-up as well as high default rates. With regards to staffing, they did indicate that many staff are taking transfer out of the municipality, leaving a few staff behind. These few staff, due to workload pressure, are also suffering from low morale and no motivation. With regards to the testing, the testing was reduced mostly due to mobility and not stockouts. There were enough test kits, there were enough ARVs, but the challenge had to do with mobility. First, there was a ban on motorbike riding. National Security thought it wise to ban the use of motorbike because motorbike was used to propagate a crime. So, but motorbikes are the main source of transport in Bawku. With the ban on the motorbike, health workers could not easily get to the facilities where they work. Clients also found it very difficult to get to the ART sites to adhere or to take treatment. Not done yet. And also there was division in the town. There were the fielding factions were controlling certain areas, and one could not easily move from one conflict zone to another. You couldn't easily cross conflict lines. So this affected ability of health workers to work. It affected community service, among others. Then there was, in view of this, there is a need for a conflict-sensitive HIV service model. Next slide. So in conclusion, I put down some recommendations, and we recommend that we strengthen decentralized care models, enhance community-based outreach, and integrate HIV services into emergency health strategies. We should have an emergency preparedness plan, especially at the district level, because we live in a world of uncertainty. We didn't know how COVID, we never thought of COVID and how COVID came in and impacted the world. Uncertainty can come in the form of conflict, and there's a need to have or to integrate HIV services into emergency systems at the district level. It's also important that we look at the staff there in the conflict areas. One thing that I also advocate is that government can employ qualified indigents who already live in Bawku and are ready to work there, so that they don't have the problem of trying to get workers from outside the municipality who may be unwilling to work in conflict zones. The few staff who are there also need to be looked at. They will need psychosocial support. They will need stress management programs to be able to function effectively. Having said that, I would like to bring my presentation to an end. These are the references. Thank you so much for your audience.
Give him a hand too. He has taken his time and even given us a little bit more. So, but I think for me, the real message is for us to prevent lack of access to services is to have peace. So I'm really hoping, to this morning, we had news of a coup in Benin. And I'm really hoping that our Africa starts, silences those guns, and we start focusing on peace and the health of our people. So I'm opening the floor to questions and comments. I'm going to be number one to ask the question. The question that I always ask people who talk about community, community health care workers and all that, to say, Baffa, are those TBAs paid, or they are workers volunteers?
Hello. Okay. Thank you so much, Ma, for that question. So those traditional birth attendants are not being paid. We just empower them, train them. However, they were given BP apparatus, tape, and also a fetoscope. This is just to help them implement what they are doing. The danger of paying them, we understand the danger of paying this traditional bartender, because for sustainability, even when this project is not there, we want them to continue this work. So they are not being paid. They do their job as usual when this pregnant woman come to meet them for any services. So they are not being paid. Thank you.
Okay, thank you very much. But the advocate in me, having been a minister in paying community healthcare workers as early as 2004, I really would like to say a lot of these volunteers are women. And the gender activist in me says they get to be exploited. If these were males, most of them, they would be paid, even an allowance. So it's really to say, if we are going to have good healthcare continuity, we must strive to find a way to either give them an allowance that will say it's an allowance for transportation or something, but not just for them to volunteer their time and everything. After a while, they get drained. They are the backbone, but the backbone does get broken sometimes. And we have to keep that in mind. Yeah. So more questions are, yeah.
Yeah, good afternoon. My name is Chief Mrs. Aduni Udu. I'm from Nigeria. I'm the MD CEO of Acons Nigeria Limited for the traditional birth attendants. when you train, after you train them, what percentage of progress did you see? You know, how did you evaluate it? What is the percentage of success? Maybe they were at this 10% before, after your training, maybe they are 50%. I want to know that. And for the other gentleman that spoke, when there is conflict, you are saying it challenges the collection of drugs and administering the drugs and things like that. And you mentioned something about COVID, which I don't quite understand. But I want to know if you know details of how COVID impacted or HIV patients. Is it true that most of them lost their lives during COVID? You know, if you can clarify that. Thank you.
All right. Baffa? Yeah.
Thank you so much, Ma, for that question. So, however, I earlier stated that am I audible, please? Okay, thank you so much. So I earlier stated that after training of this traditional birth attendant into the program, we noticed over 2,000 for the positive pregnant woman. We noticed 25%. We were at 5%. Then identification, we found out more positive pregnant women. So we were coming from 5% to 25% in 6 months. Then in terms of also testing of this pregnant woman, we were moving, we are at 1,000, then we were at 1,000 plus, then we moved to almost 56,000. So these are the percentage, and you could see the amazing performance this traditional birth attendant when we engage them. Thank you.
Thank you. Bill? Yeah, it's yours.
Okay, yeah, sure. Hello. All right, so I did indicate that we live in a world of uncertainty, and therefore there's a need to put in place a preparedness plan. And I cited COVID as an example. We never thought of COVID, but then COVID struck the world. And because some countries didn't have a preparedness plan in place, or didn't integrate some of these circumstances in their emergency situations, it did cause havoc in some areas. So just like COVID, I was also saying that conflict can erupt anywhere. And for us to be able to deal with conflict and to deal with the effect of conflict on HIV service delivery, I was recommending that we include HIV service. We include HIV preparedness plan in our emergency situations, so that if a place is affected or a conflict erupts in the place, because we have a preparedness plan in place, we can effectively still cater for persons living with HIV and AIDS. Thank you.
Thank you. Some more questions and comments, please? Raise your hand and the mic will reach you.
Thank you. My name is Jamel Hamadesh. I'm part of Vive Healthcare Positive Action. I'm just interested in the traditional birth assistants, and I'm wondering whether there's a proportion that is reluctant to be trained by, your services, or if it's government guided training or anything like that. And if there is indeed a proportion that is not willing to be trained, then what would the reasons be?
Hi, thank you for that question. So, like I earlier during my slide, we have more than 168 traditional birth attendants. Definitely, there are other traditional birth attendants. What we did was to map in those community. We used the traditional birth in those community that are prominent, and then people believed in them. Even among those in those districts, there are there are some that are more prominent and more trusted in those communities. So definitely there are some. So we also have a sustainable plan in our rollout phase that those that we were not able to train in that district, the ones that we train will also cascade it down to them, of course, after that. I don't know if I've answered your question, but that's something that I have thinking.
Sorry.
I think I get where you're coming from. You know, before, when the Bamako Declaration was done, when was it, Professor Liu? It was the realization that in communities there are women who are helping other women, you know, to give birth. And most of them are usually relatives. So it was really to say, if we are going to bring down maternal and infant mortality, we have to start at community level with these women. And that's, I mean, the community was willing for them to be trained, they were willing to be trained. But as history goes on, you then get somebody who decides, I'm going to be a traditional birth attendant, I want to be trained, and maybe the community doesn't want them either. So there has been that problem, even with community healthcare workers. Community healthcare workers ideally should be from that community, you know, elected by that community, selected for training. But some people just go in and say, I'm a community healthcare worker, you know, I've been staying in some locality, therefore I'm here. And that's imposing people on, you know, yeah. So I think I'm hoping that she answered your question, but you can go ahead.
Is it okay? Thank you.
Next question.
Again, when you're from Ghana? Yeah.
Let's go up.
Oh, okay. And a few days ago, I was looking at a receipt. I bought something, and I saw COVID tax. And in talking about preparedness, I think that's a good example from Ghana for the rest of Africa to learn from. And I understand you people are still collecting COVID tax, right? Ghana. Because that will help us. If anything, we God forbid, we don't want another repeat. But Africa was not prepared. Africa did not have any reserve for funding. And this thing about Africa always looking for handouts. We have to be self-reliant. We have to protect ourselves. And I think Ghana did very well for that and is still doing it. And if other African countries can follow, it will help us for emergency situations. Thank you.
Thank you. Anyone? Oh. Okay. Give them a hand. I think they said it all, but you also have a chance to meet them individually. But you know, they have talked about the structural determinants of HIV. I mean, just only two. We know there are many, and one of them, you know, some of them being weak health systems. The fact that we have healthcare workers who are not properly, you know, trained, properly maintained, and probably properly retained at home. So it's really some of that, and we need to then see how do we ensure that when we get to health system strengthening, we are talking healthcare systems, not just at public health level, but also at very real community level. So with that, let's give them a hand again. And I'm also happy to talk about you know, any of that, because the traditional birth attendants were really, that declaration was crafted by people like me and her. I mean, we are the dinosaurs of the AIDS response, so we have quite a few answers, at least to the history. Yeah. So thank you very much for coming. Yeah.